No, this is Carol Reinking speaking. And according to my watch, it's 7 o'clock. So I would like to welcome you all this evening. I have a few announcements to make, and then I'll turn it over to Joanne. I am a co-president of the League of Women Voters with Joanne. And just a reminder that our next membership meeting will be February 16th, and there'll be Planned Parenthood programs in Illinois. And then on February 18th, there's an issues briefing from the League of Women Voters of Illinois. And then on March 16th, we will be meeting at St. John's United Methodist Church. We were scheduled to talk about affordable housing, but there's a possibility that either Dr. Shelton or someone from the school board or the staff at the school district will be speaking to us about the upcoming bond issue. So we'll let you know which one of those will be being presented on March 16th at St. John's. Okay. Joanne, would you like to introduce our speaker?
Yes, it's my pleasure to join us tonight with Pam Gronemeyer. Pam is a member of the League of Edwardsville area. She joined through the National League. And Pam is a degreed pathologist, board certified anatomic and clinical pathologist. She got her undergraduate degree from Washington U in St. Louis, attended Tufts University School of Medicine, and her pathology residence at New England Deaconess Hospital in Boston, Barnes Jewish Hospital of St. Louis, and St. Louis University Hospitals. She currently has a small SEMC pathology business, which services 7 area hospitals in Southern Illinois. I know Pam, she was my boss. She was the pathologist at Wood River when I was the lab manager. And the other thing we have in common is we both grew up in St. Louis City, which always begs the question of where did we go to high school. We did not go to the same one. Pam went to Southwestern and I went to Cleveland, but not at the same time, of course. So I'd like to turn the meeting. This is a big issue on healthcare right now, and I'd like to turn the meeting over to Pam. Thank you.
Hi, everybody. Yeah, thank you for having me. And I'm glad to have finally gotten to meet you guys in person, because basically what I did was I heard about the National HCR for Us, which is the Healthcare Reform for Us group in the National League of Women Voters. And I've been participating in that on Sunday evenings, but there's nobody else from Illinois in it. And there are people from other states, but I mean, I think that we need to get involved in it, and we need to, know what's happening. And because I mean, this is a really time where things could change fast and not very, not have a good outcome for seniors. Okay, so what I'm just gonna start with was we gave you you have a copy of the League healthcare toolkit, which I think that it had probably with a link of how to get to it in the email. But okay, basically this year, not this year, last year in 22, many single payer advocates went to the National Convention or the concurrence, and we're trying to support healthcare, single payer healthcare. So if you go to the first box, the League position on healthcare reform, there were changes in the League's position for healthcare. I mean, these are going to be changes that are going to appear in a new statement in February of 2023. Now the League favors a national health insurance plan financed through general taxes in place of individual insurance premiums. The League is opposed to a strictly private market-based model of financing the healthcare system. The League supports increased taxes to finance a basic level of healthcare for all U.S. residents, provided healthcare reforms contain effective cost control strategies. And the League believes that the ability of the patient to pay for services should not be a consideration in the allocation of healthcare resources. And I mean, these are significant changes because I think the league has been pushed farther with the fact is that in 2010, the league supported the ACA. And I mean, since the ACA was really all we had, I did have to support the ACA because we had to have healthcare reform. But now we've seen that the ACA is not the answer because we have like 60% of people with employer paid healthcare or employer provided healthcare are underinsured. They don't get the healthcare they need because their premiums are too high and their deductibles have gone up so much. I mean, in the olden days, deductibles, were like up to maybe 500, 1,000. Now they're like 5,000, 9,000. So people can't afford, they're afraid to go to the doctor, even though they need to go. So I think it's good that the league is, that we're moving forward. And, I had belonged to the league before, and then I dropped out for a long time and I got involved in some other things, but I'm trying to get allies. I mean, if we have progressives, that a progressive one in one area, progressive two, we need to somehow be unified because the more numbers we are, the louder our voice is, and the more people have to listen. And just to remind you, I was the person who got it on the Edwardsville, who got the resolution on the Edwardsville Township ballot that endorsed improved Medicare for all. And I used the April annual meeting of the township to bring in my petition with at least 15 good signatures. And we voted on it at that meeting, whether it should be on the ballot. And it was on the ballot, and it won by 74.4%, which I think is pretty good. And when I went back and compared how many, there's no way to really pull out the township vote from the other candidates, except for I looked at the two board members in Edwardsville and the two board members in Glen Carbon. And basically they got about 8,500 votes, the Democrats, and we got over 9,600. So I think we did have some non-democratic voters voting for it, which is basically the history of Medicare for all. Okay, so and here are the steps they've taken in the past: testifying before Congress, joining coalitions to support bills like HR 1976 was Jayapal's bill in last Congress for single payer, and supporting grassroots reform. And we basically, what's we're up against is the unprecedented growth of private equity investment in healthcare. I mean, they've now, private equity wants to make money off of healthcare. I never thought of healthcare as a cash cow, but they want to make money off of it. So what they're doing is they're buying doctors' office, they're buying doctors' practices. I mean, a lot of the ER groups, a lot of the anesthesia groups, a lot of the radiology groups, they're owned by private equity. And I mean, private equity, it's basically, they have to make money. So it's really not, we're also creating a group of doctors that can't really voice their own opinion, because if they work for a private equity firm, if they talk too much, they'll lose their jobs. So, it's not a good position that we have so many doctors groups getting acquired by private equity. In addition, we have a lot of merged hospital groups, and that's not good. And then we're going to talk a little bit later about the REACH program, because private equity wants to get in the REACH program. And I really don't think there's any place for, privatization in healthcare, because it's patients over profits as far as I'm concerned. And I took an oath to make sure that to try to improve the health of my patients, not to try to make a small fortune for a shareholder. So I think that, look at this, the private equity in healthcare, 2000 to 2020, 25-fold increase in 20 years. It's ridiculous. And they've had studies, and there are many, many videos and webinars about private equity and group. And I post a lot of those on my Southern Illinois People for Progress page. So life, liberty, and the pursuit of something a little more like Canada. That's probably really what we need. Okay, then we're going to go back. We're going to go to the next thing. Single payer overview. I think you guys all know what single payer is. Single payer is basically improved Medicare for all. Basically, what we want to do is not just have Medicare as it is, because we know Medicare as it is lacks vision care, dental care, and eye care, no, and health and hearing care. We would like to be able to offer what the Medicare Advantage plans claim they're offering and put it all together for everybody. So you will have Medicare, improved Medicare for all from birth to death. And we're not talking about free insurance. We're talking about insurance that is paid for. I mean, basically, I'm a small business owner and I know how much I pay. I pay $5,600 a month for my employees' premiums. And I only have like 5 employees. I pay it to United Healthcare. I would much rather write that check to the federal government as a payroll tax. Because I mean, I really, United Healthcare, every year my insurance goes up and I can't predict. I know if with Medicare, it will be consistent. I can at least figure out if it's going to go up and it's not going to jump. At times it went up 16%. So, I mean, single payer is definitely the way to go, where we'd be given a card at birth and we would go into the hospital or go into the doctor's office, would have no copays and no deductibles and no premiums, because it would all be, it would be covered. And I mean, we know that right now, the overhead for Medicare is about 3%. And the overhead for private insurance plans is about 20%. And they have to be making money, they advertise. I mean, advertisement's not free on primetime TV. So, I mean, it really makes sense. So they have a few terms in here. The one thing that we're going to talk about a little later is accountable care organization. And that's a form of managed care with physicians and hospitals are generally incentivized to work together to try to achieve greater integration of care and cost saving. And these things have cropped up, and what's happened is a lot of, like the HSHS medical group has an ACO where all the doctors belong to it. And basically, I mean, they're theoretically controlling the cost, but the ACO, depending on who owns it or how it's run, is not necessarily going to guarantee you the best healthcare. And you're also going to have a limited number of doctors you can go to. So we're going to go to the next one. I'm just going to go through these things. What single payer isn't? It's not a public option. It's not Medicare for some, and it's not Medicare Advantage. It's not managed care, and it's not socialized medicine. Socialized medicine is the VA hospital, where the doctors and the hospitals are owned by the federal government. We're talking about Medicare for all. We're talking about privately delivered, publicly funded. And it's publicly funded, but it's funded by the public. We participate by paying taxes into the pool so we can get our health care. And I mean, there's, and it got socialized medicine. Every time I would go see Rodney Davis, who was my congressman, he would tell me that about socialized medicine. It's like, Rodney, it's not socialized medicine. Then he would tell me how much people hated the VA, which is not true. The VA may be underfunded, but in general, the veterans are fairly well satisfied with their health care. And they reached out when they didn't have the providers like GI specialists in certain areas. They allowed them to go to other private GI people. So, I mean, the VA tries to, adjust. And I mean, but he would always tell me about socialized medicine. Okay. Go back. Okay, how will we pay for it? Okay, that's a question everybody has. And I myself favor an increased payroll tax that I pay for my employees that will replace my current premium payments that I pay every month. And I'm unusual because my employees don't pay any premiums. I pay all the premiums, they pay their co-pays, and they have a deductible. I try to keep them at a deductible or $1,000 or less. Because my employees are my friends and they're vital to my business. I want to keep them healthy. And they had a lot of good saves in the people who work for me. I mean, one of my employees had atrial fib and she had like a TIA, and then she got the atrial fib fixed. And I mean, that was all on the healthcare insurance. So, I mean, that was good because Lisa's a good employee and I want her to be around for a long time. So, and I mean, basically, they estimate the cost, and basically, the Congressional Budget Office did a review last year, and it will cost less than our current costs for Medicare, for healthcare. And then we won't be paying the United Healthcare CEO who gets, in the millions, and all the other CEOs of insurance companies getting the millions. That'll go away. But, I'm sorry. I don't really know what they do to earn their money. So, okay, we're back again. The reason I'm doing this is because I'm focusing on what the league wants to do. Proposed legislation, I talked about 1976, which is Pamella Jayapal's bill. She's the congresswoman out of Seattle. And then also Bernie's bill, Senate 4204. Basically we need to, really Medicare for all and single payer really started coming to the fore when Bernie started to run for president in 2016. So it began to get a place in the public media so people would learn more about it. Now, still people do not know everything about it. But, I tried to do my part by going to the market on one Saturday a month and having a booth and trying to do, township halls or get some of the candidates who are running to come and talk about healthcare. I'll continue to do that because I think, we need to spread the word. We also need to create, not only spread the word, we need to create activists. There is also some state-based advocacy, and that's a one-payer state group. And they're working on the fact that they would like to get at least one good big state having single payer. Of course, what had happened, they'd have to get the Medicare, Medicaid money from the federal government that is allocated for their citizens. But California almost did it. New York's working on it. Washington and Oregon are working on it. And some people have suggested that you could have a combination of California, Washington, and Oregon. But, I'm for any way we can get it. If we can get one, and that's what happened in Canada. In Canada, Medicare started in Saskatchewan, which was Tommy Douglas's original province, started in Saskatchewan. And then everybody else saw how well it worked, and they all joined in. And really, they're like funded by each province. They're a little bit different in that they're, it's really the provinces fund theirs. But everybody gets a card and they go to the hospital doctor. They don't worry about like losing their house over their medical expenses. It just, it makes sense. I think that, I believe that healthcare is a human right. Now, I can't tell that to everybody because some people that just set some, nothing's a human right or you have to earn it. But, the problem is that it's hard to earn it because now many small businesses don't provide healthcare insurance. And the healthcare, Walmart, healthcare insurance for their employees is called Medicaid. And in like nursing homes, fast foods, what happens is they hire people part-time and they don't have to give them benefits. So, we just we could do better than we're doing. So, okay. In the media, and how it's gotten in the media. It's just these are a few articles they put in here. And we took out a full page in the New York Times to celebrate the American College of Physicians endorsement signed by 1,000 physicians. As physicians, we prescribe Medicare for all in 2020. We're getting more and more press, and I write letters to the editor about Medicare for all, but I usually send them to the Post because basically, if I send a letter to the editor of the Post, they usually publish it. So, I think that, we need to get the word out about Medicare for all. And sometimes what happens is I'm just talking to people who know about it. We need to get out and talk to other people. And then allied resources, I think they have a resource page. They have documentaries, and there's actually a new documentary coming out. This documentary, Fix It, was by Wendell Potter participated in it, and it was actually it was about a business owner. It was a small business, but small business. He had like 200 employees, and why he liked Medicare for all. So there have been two that have been put out by Wendell Potter and this, I think his name was Majors, and now another one's coming up that I saw when I was in November. I went to the Physicians for National Health Program meeting, and there's another one coming out, and it's about hospitals. It's about what part hospitals play, and how not-for-profit hospitals are really not-for-profit. And I mean, it's just addressing the hospital issue too. So that will be coming soon. And I already saw it was pretty good. And these are some good books. I mean, I have copies of Medicare for All by Gerald Friedman, because Gerald Friedman's an economist out of Amherst in Massachusetts. And he is, a big supporter of Medicare for All. Deadly Spin is Wendell Potter. And Wendell Potter was originally a person who worked for Cigna. He was a spokesperson for Cigna. And he went to one of those in the South. There used to be someone who was I think he was from Australia, who would run free clinics for people once, like a day or two a year. And he went to one of those, and he saw how many people were waiting to get any sort of health care. And he realized, I'm working for a company that isn't helping people, it's hurting people. So he split from the insurance industry, and he's become a big proponent for single payer. I mean, all these are good. I mean, good books. And I have copies of some of them. So, but, and now how to get involved. Okay, getting involved. Okay, join our advocacy network. That's the HR for Us. And you can join it. You can participate in the phone calls. And I'd like to have somebody more than just myself from Illinois. And I mean, the problem is they're at 8:00 on Sunday night, and there's one coming up this Sunday. But it's very interesting, I'm really enthused. I always get inspired when I hear people who believe what I believe. And by getting inspired, it increases my enthusiasm and my ability to push on. I'm one of those people, I like to be upbeat. And I mean, I get really stirred up when I find people who agree with me. So I think that, and this toolkit is very good from the League of Women Voters. I also, Joanne, I think, sent a link. Every month they're now coming out with a newsletter. And we also have meetings on Sunday. We're going to talk about like activism, what we can do, and how we should move things forward. So anybody have any questions?
Yeah, I've got a question.
I didn't put you all to sleep, did I? Huh?
No, I was gonna say, I have a question.
Yeah, I'm here.
Several years ago, I was down in Florida because my father had a cardiac arrest, and we were at the hospital. And of course, in Florida, there's a lot of Canadians down there around Naples area. And one of the fellows in the waiting room was actually a doctor from Canada, whose brother had some kind of issues, and he didn't even like the Canadian system because they make you go through all these tests. He says, I could have told him what it was, but they wouldn't let him have the treatment that he needed. And so a lot of Canadians will come to the United States because they're able to get treatment. And I was just kind of surprised, since that was a doctor versus a politician saying that. But he seemed to feel that.
I don't think if actually, sometimes a lot of that is there are not a large number of Canadians who come down here. And sometimes they come down to jump the line, because in Canada, it's done, you get in line.
Yeah.
So, unless you're not going to get in line if you're having a heart attack, or you're not going to get in line if you have a ruptured diverticulum, or if you need immediate care, but you do have to wait. And, it's stupid to believe that Americans don't wait for knee surgery and hip surgery. And quite honestly, I'm of the belief that sometimes if you wait, it heals itself. So sometimes rushing into things isn't perfect.
Yeah. Because this was a neurological type thing. And so that was it. He would have to probably go through everything and be about 4 or 5 years before he could actually get the treatment that he needed. But that's just one of those are the kind of I guess, discussions we have to have the response to, like you said.
Right, but I think that, that if you look, there are very few Canadians that do come down here, and a lot of them come down here depending on their province. Because you remember, every province isn't as rich as every other province. And sometimes the provinces, like, if you look at the provinces like Nova Scotia, they're not going to have as many ability to cover things as other ones like, the bigger provinces like Quebec or Ontario. So therefore, some of them will come down, but it's also was said that Canadian doctors come down here. They don't. More American doctors are going to Canada.
Okay.
And
That's good to know.
realistically, I'm a pathologist, and pathologists are not getting any younger. They have a shortage of pathologists in Canada. So really, except for self a cold, and I don't really want to give up, move, but it's just that, and they'll tell you all these like, that they told one about the woman. Well, there's a woman out in San Francisco, and I'm blocking on her name, but she's belongs to the group in Canada that's like the Heritage Foundation here. And so she was talking about a person who had a brain tumor. Well, it was a benign, it was a pituitary adenoma, but it was not a malignant tumor. And they just overtell the stories. I think that what happens is sometimes they do come to jump the line. The richer ones do, because they want to get, because down here you can find somebody to do something for money. Especially, if you've got, if you come in with money and you're not going to be run through Medicare, and they're not going to have to take what Medicare pays, you're going to get to the top of the line. So, I think that there's a lot of this is not necessarily true, but it's something that we always talk about. And I've got some articles, and actually the best article I ever read was a cardiologist from Texas who was the head of the American Society of Cardiology, who's a Republican, and wrote why he believes in Medicare for all. And Ed Weisbart had the thing about how you try to appeal to conservatives on, what makes them happy. Strictly speaking, it's supposed to be, it's cost saving. So therefore, conservatives don't like to waste money. And I thought conservatives believe in nationalism. And what could be more nationalistic than you taking care of everybody? Because we are, I think we are our brother's keeper. I don't care what they say. And we saw in the pandemic what happened. You can't create a barrier. A mask help, but everybody across probably all economic levels came down with COVID. And we did really badly in COVID, because what happened is people lost their jobs and they lost their health insurance. Because their job right now, if you have employer health insurance, it's tied to your job, and if you have no job, you have no health insurance. And if you've ever had to pay Cobra, you know how expensive Cobra is, because people don't even realize how much health insurance costs for their employer. So, there are a lot of things.
I have a question about Medicare Advantage. Is that funded through the government? Does the government give these companies X amount of dollars per month?
Oh yeah, they do. They give them it's a capitation, but they get paid 11%.
Do you know how much that is?
Well, they get paid 11% more than conventional Medicare.
So
that's what
that money could actually be used for Medicare for all.
Oh, right. I agree. Medicare Advantage. What happens is the insurance companies get paid, and that's why you have to go through pre-approval, because the less they approve, the more they make. So therefore, and can you see the Medicare Advantage thing that I put up there now on the screen?
Yeah.
Okay, yeah, because I was going to talk about Medicare Advantage a little bit too.
Yeah, okay, go ahead and talk about it.
Yeah, this is Ed Weisbart's a physician in St. Louis who's done a lot of the PowerPoints for PNHP, and talking about, the Medicare Advantage, and I tell everybody to do traditional Medicare, because the problem with Medicare Advantage, you have to go through, you can't go to the doctor you want. You have to go usually through a gatekeeper, and they have to approve you before you can go. They have smaller networks than Medicare. And they also, they can deny you care. They can deny you if you need certain chemotherapy, they can deny it. The other thing about Medicare Advantage, which is telling, Medicare Advantage, none of the Medicare Advantage plans in New York City have Sloan Kettering as one of their cancer providers. And Sloan Kettering, I mean, it's, an excellent place for cancer care. I listened to a video, an audio webinar yesterday about breast cancer. And I mean, they're down to the genomics of breast cancer, and all these drugs, they can see where they affect what stage in the cell. I mean, it's amazing. So how can they not have a center of excellence like Sloan Kettering to offer it to their members, because they don't want to? The biggest problem with Medicare Advantage, it sounds good, Joe Namath or Jimmy Walker or whoever's advertising it on the TV. It sounds, I mean, you can say, well, you even get money back on your from your Social Security, and you don't have to pay any premiums. You don't have to, but you do have to pay co-pays. And people are being sold a bill of goods. I mean, I would never go on Medicare Advantage. I mean, I know this because I was a friend of a woman who used to work at Granite City, who was elderly, and she was in the hospital at Granite City, and she needed to go to a rehab center. The number of rehab centers that were on the list were certainly not the ones I would have picked, but that's what they had in their network. And about 4 years ago in St. Louis, the Medicare Advantage plans kicked off 200 specialists from their plans. So therefore, they made it harder for you to get a specialist. So I mean, I don't like Medicare Advantage. So here, but the percentage of Medicare beneficiaries, Medicare Advantage is growing. I mean, I think it's almost up to 50% of the market, because the commercials appeal to people and people don't know the downside of it. I mean, and what's happening is Medicare Advantage, if it takes over Medicare, all of our Medicare will be privatized. I mean, 100% of Medicare recipients go to Medicare Advantage, it will be run by the private companies. And boy, once you let them go, it's a monopoly.
The beauty is, if you're not that sick, you pay zero, you don't really go to doctors, you're fine. But if you get sick, that's when the
right, and that's what
arises.
they do. They call it cherry picking.
Yeah.
They pick out the best patients, but when they get you enrolled, they get your whole chart. Then they go through your whole chart and they find anything that they can put as a comorbidity. So they upcode people. People that are healthy become sicker and they get more money. They get more money per comorbidity. So it gets adjusted up by how much money they get per month, as on their capitalist in their, what happens is they're paid so much per person who's enrolled per month. So it's capitated, and it's not the way to do it. I mean, Medicare for all, we could have more control, and we know we've saved more money in Medicare than we've saved on Medicare Advantage. In addition, I mean, people who are 65 or older in Medicare do have the best health in cancer survival than they have before 65, because Medicare lets you do what you need to do. Okay, actual Medicare care, not overhead profits, and that's what it is. They're insurance overhead profits, and there's no solid research comparing clinical outcome between traditional Medicare and Medicare Advantage. And I mean, all of our quality studies that we do in the hospitals are developed by Medicare. They're not developed by Medicare Advantage. So I mean, I just, and 2% overhead means traditional Medicare is simple and efficient. 15% overhead or more, and profits mean Medicare Advantage is complicated and inefficient. I mean, managed care tools, prior authorizations, step therapy, smaller networks, shun the sick, seek the well. What happens if you get sick, then they lemon drop you. They cherry pick you if you're healthy, but once you get sick, they lemon drop you. They don't want you in their program anymore. And they have to be making money. How can they hound you on the phone? I mean, I don't know how many phone calls I got from Medicare Advantage, and I'd say, "Are you the government?" "No." "Bye." I mean, it's ridiculous. And I mean, I'll tell you, with Medicare, Okay, when I signed up for Medicare, they gave me a time and a date for me to call to get my Medicare. And they called me on time and they gave me, I got Medicare. It's the same thing. I mean, with Social Security. Today, I mean, I've reached age of 70, so now I'm going to start taking my Social Security. Today, the woman called me on time to make sure I had all my information right, on time and the right date and the right time. And she was very nice. So, I mean, I just think that the government does a lot of things that nobody wants to give them any credit for. Okay, shun the sick, high overhead and profits, accusation, fines, settlements for fraud. I mean, they are getting fined for fraud. And there also have, I mean, there was an article in New York Times, and I can give that, I can put that on for us people to read, that talks about Medicare Advantage. And they've done studies at the Kaiser Healthcare Network. I mean, has requested to see the outcomes in Medicare Advantage. And they're finally going to really have to release some of that information. Okay, Humana overcharged Medicare by nearly $200 million through upcoding and overstating how sick some patients were. Recommendations to repay if finalized would be by far the largest audit penalty ever imposed on a Medicare Advantage plan company. Sutter Health settled for $90 million for knowingly submitting fraudulent diagnoses. I mean, they look at your chart, if you fell and stubbed your toe when you're a kid, that's probably on there. The largest false claim act settlement ever paid. And I mean, they're starting to watch Medicare Advantage really carefully. Okay, many Medicare Advantage have been accused of fraud by multiple reliable sources. I mean, these are the groups: United Healthcare, Humana, Kaiser. Well, Kaiser Permanente. Now, the problem with Kaiser Permanente is the people in California love it, but it's almost all that you can get. So that's the problem is when we talk about single payer there, we run into the Kaiser Permanente people. And the Kaiser Permanente people are different from the Kaiser Family Foundation, which does a lot of the healthcare work for investigation and studies. I mean, overbilled per U.S. Inspector General, accused of fraud by U.S. government, accused of fraud by whistleblowers. And the many MA plans have been accused of fraud by multiple reliable sources. Accusations, settlements, penalties, and fines are not as, clearly they're not as potent as conviction and exclusions from federal program. Hence the ubiquitous, no admission of guilt. Medicare pays more to Medicare Advantage plans for patients with a higher risk score. That's why they want to upcode you, because the more comorbidities you have, the higher your risk is. Reimbursements for HCCs and Medicare Advantage is based on expenditures in traditional Medicare. I mean, it's basically they pay, traditional Medicare pays bills. And I mean, they're adjusted by what they use as their fee schedule, but Medicare every year disseminates the pay schedule, the fee schedule, and they observe it. And doctors may not always be totally happy with it, but we've learned to accept it. And I don't know if how many people remember Medicare when it started. Nobody was going to belong to it. And then everybody belonged, all doctors belonged to it. So because risk scores are worth so much money, Medicare Advantage have become masters of coding. That's what they do. They teach you how to upcode, and they encourage your doctors to upcode. And I guess if their doctors aren't coding enough, they get in trouble. Uncorrected Medicare Advantage coding intensity drains millions of dollars from Medicare. And it's never generated savings relative to traditional Medicare. In fact, the opposite is true. Medicare Advantage overbilling exceeds entire agency budgets. And that's the problem. I mean, what's happening is, we have right now a lockbox for Medicare, how much is in Medicare. I mean, the more Medicare Advantage explodes, the more it's going to be eating up our lockbox. And that's why they keep saying Medicare is going to run out of money. Well, I mean, basically right now, medical care in the United States is like 18% of the gross national product. And if it keeps going up, we pay more than any other country in the world for healthcare. And our outcomes are not, if you have money, you do fine. And we have excellent healthcare, but this is the first time we've seen white males over the age of 50, their longevity decreasing. I mean, we're seeing people living shorter amount in the last 2 years or 3 years. I mean, some of it may be over, drugs, it may be over alcoholism, or it may just be over depression, or it may be over, the burden of healthcare costs. Medicare Advantage plans are allowed to create their own proprietary coverage rules. They use clinical criteria that are not contained in Medicare coverage rules. People in fair or poor health have even more cost-related problems in Medicare Advantage. And here, this is what I was talking about. Cancer surgeries at the top ranked hospitals, Medicare Advantage compared to traditional Medicare. They don't go there. You're talking about, these are like a colectomy. Depending on how you do the colectomies. Now so many of them are done laparoscopically, and you don't take out so much like you used to take out. Whipple procedures, which are, really require a high technical amount of work. In their final year of life, patients leave Medicare Advantage. But the problem is that if you leave Medicare Advantage and you go to traditional Medicare and you apply for a supplemental, then you have to fill out a health chart. You have to fill out a health questionnaire. When I applied, I went right into traditional Medicare and I got a Blue Cross Blue Shield supplemental, and I didn't have to fill out anything. I just signed up for it. But if you are in Medicare Advantage and you drop out and you want to go to a traditional Medicare and sign up for a supplemental, they can make you fill out a questionnaire and you may not get coverage. It's so bad. Why do so many people sign up for Medicare Advantage? Despite all this, the low premiums and perks may still be attractive to seniors who are not yet sick. The situation often changes when they develop an illness. And actually, this woman, Jessica Shore Sachs, was in my medical school at Tufts. It's so bad. Why do so many people sign up for Medicare Advantage? Traditional Medicare, 40%, because of more choices. That's why they go to traditional Medicare. 9% because they're recommended by trusted people. 7% continuing employer coverage. 6% VA TRICARE, and 4% lower costs. Medicare enrollees, 24% for more benefits. Like you get your silver sneakers or whatever, or you get your gym membership. 15% because it was recommended by trusted people, and I don't think that was probably Joe Namath or Jimmy Walker, but 11% offered by former employers. And what's happening is that I actually think Illinois state employees had to go into a Medicare Advantage plan because that was the deal that the state made with them because they thought they could have better control, and it was a bad idea. Now in New York City, the mayor is trying to get all of the municipal employees on a Medicare Advantage plan when they retire, and they are fighting it. They have many protests, and they are fighting him hook, line, and sinker. Because they do not want it. It's so bad. Why do so many people sign up? Okay, we have, traditional Medicare isn't perfect. We have 20% co-insurance, 1,600% hospital deductible, no out-of-pocket limits, and there are premiums for Part D, B, and Part D. Okay. Just to show, Medicare Advantage, the Medigaps, which are what I call my supplemental, 200 per month, 18. It shows you the difference. 0 out of pocket, no additional benefits beyond traditional. Identical to traditional, but it's not identical to traditional Medicare, and you have much smaller networks. And rare and only as required in TM, utilization management typically is proprietary prior authorization. So it's basically what you're going through now with your private insurance. If they have to and people have to spend their life on the phone trying to get them to authorize it. It's so bad. Why do so many people sign up? I'll start with the free Advantage plan and pay the extra for Medigap, but the Advantage plan won't let me see the doctors and plans I want. And so this is where they're talking about medical history. After 6 months, insurers can require your medical history and refuse to offer you a Medigap. And that's why you really should go to traditional Medicare first. 4 states required a guaranteed issue for Medigap plans, and the 4 are Connecticut, Massachusetts, New York, and Maine. And then 8 states require community rating. Insurers must charge all policyholders within a given plan type the same premium without regard to age or health status. So there are controls on the Medigap plans. And deceptive marketing practices flourish in Medicare Advantage. We've all heard it. Medicare bus goes to an insurance broker. Medicare Advantage enrollment mailer designed to look like an official government tax document. More and more seniors are complaining about Medicare Advantage lies. And I've got a list of, I've seen lists of people complaining. Agents often receive annual commissions at 50% of first year level to get you into a Medicare Advantage plan. So the agents are not working for us either. Okay. 80% CMS secret shoppers of insurance agents calls with clients. 80% of calls were inaccurate or insufficient. That's why I always said, are you the government? And then they'd say no, and I'd say bye. Target your message to patient. Medicare Advantage total cost may surprise you when ill. Medicare Advantage promotions are often deceptive, fraudulent, and predatory. Pre-existing conditions may prevent you from getting health, from getting a Medigap plan. And then this is just for physicians. And actually, many physicians support Medicare for All. The College of American Physicians does. Internists do. Family practice do. I wish I could get the pathologists to do it. Every time I try to get to talk to somebody, they never call me back. And the single payer prohibits prior authorizations and step therapy to legislatures. Tell them Medicare Advantage is popular because it's free ice cream, and it's not really free at all. Medicare Advantage has never generated any savings compared to traditional Medicare, and many Medicare Advantages have been accused of fraud. That's why we have to protect traditional Medicare. And we need to make it improve by eliminating copays and deductible, creating an out-of-pocket maximum of ideally zero, match or exceed Medicare Advantage benefits by including vision, hearing, dental, and pharmacy. We need to expand ACA patient protections to Medigap, and we need to strengthen patient protections in Medicare Advantage. We need to really protect Medicare. And this is, okay, then I'm going to launch into the lab. Anybody have any questions? There, everybody there still? I'm afraid I lose you. Hello?
Hey, Pam,
Hello?
is it?
Oh, you're there. Okay, you're there.
We're there. I was wondering,
afraid.
do you think it's the insurance companies that really are against this, or is it like
Oh, of course.
Congress? It's
Oh,
both
no,
of them.
the insurance companies are against it. And remember, they pay a lot of lobbyists. There are like 8 lobbyists for every for every congressman. It's a huge number of lobbyists. And they support their campaigns. It's really bad. It's really not fair that we have to
So the need is
compete
really
against,
for
we don't have any money to spend on things.
Right. So you need to have a groundswell of people who are for Medicare for All, basically.
A grassroots effort.
Yeah.
And that's we really need to talk to people. What we need to find is local people who've been burned by Medicare Advantage too, who are willing, to tell their story. Because, we really know that Medicare Advantage has many problems. And it's, really, like I said, I wouldn't do it, because when I looked at the rehab choices for my friend, I took her out of her plan because I didn't think it was good, because we didn't get a choice of the best rehab places. I'm going to try to find this one thing I was going to talk about too. Oh, here. I had one more thing. I want to talk about REACH. Okay, we talked about ACOs and how they're massive groups of doctors who work together. Okay, so the ACOs. Okay, last year, well, actually, it was started under Trump. A group of his henchmen, many of whom worked for insurance companies, came up with the idea of the direct contracting entities. A direct contracting entity is somebody who works with doctors groups to enroll you in a Medicare Advantage plan, a Medicare Advantage life plan, which is really just like Medicare Advantage, by working with your doctor. If your primary doctor belongs to a direct contracting entity, then you are immediately enrolled in in their group. So you're really, I mean, you're taking out of traditional Medicare without your choice and put in a Medicare Advantage like plan. And that's what came up under the Trump administration. Okay, so everybody protested about it last year. So then they came up with a new idea. Now they call it REACH, and it's restoring, realizing equity, access, and community health. And basically, it's the same thing as the direct contracting entities, but what it does is they have a few things to prevent it from going over the top. Direct contracting entities could keep 40% of what they made or what they were paid for health care for their enrollees, for their benefit, for their profit, 40%. And that I was actually still the same in the REACH program. But REACH, they had some wonderful thing. They required that doctors be on the board of REACH plans. But the problem is, if you take doctors who work for it, how are they going to vote against it and still keep their jobs? It's just, all of the things they came up to change the DCEs to REACH is a fake. And basically, they are trying to get everybody in the United States enrolled in a Medicare Advantage plan by 2030, which means all of Medicare will be privatized. And we can't let that happen. And we can't let that happen, especially because if Medicare goes away, how can we push for single payer? Nobody will even know what we're talking about. So privatization is not, this REACH plan is a catastrophe. And that's what I gave you this. And you didn't get a copy of this, but this was just a letter that came to me from the Nurses Campaign for Single Payer. And it talks about, I was trying to find something that was a good summary of REACH because I can't really talk about it for too long, but it's something that we need to fight now is the REACH plan. And Joanne, I'll give you this link so you can send it out.
All
But
right,
this
fine.
talks, yeah, but this talks about the REACH plan, what they're trying to do to us. So everybody's armed against REACH, especially like PNHP, we have a petition. And so I think the nurses have a petition. And we need to be contacting our congressman. And we have a new congressperson in Edwardsville on the 13th. We need to be telling her not to support this REACH plan because this will kill Medicare. And then also the other thing is every year, if you can believe this, AHIP, which is the American Healthcare Industry, it's AHIP. I think it's American Health Industry Providers or something, but they're a big group. And many of the congressmen sign a letter supporting Medicare Advantage. And we don't want her to do that either. I don't know whether she did it or not, but we don't want her to do it. We need to get the word out. And that's partially why I had my thing on the ballot, my non-binding referendum, because Durbin always tells me how much people love their employer health insurance, and they don't. So I thought if I had real numbers from some place in his state to show him, because those referendums are free, it's a free poll. If you can get it on the ballot, it's not that hard to get it on the ballot. It's a real grassroots thing that Illinois has left in there. And it also passed in Urbana, in the Urbana Township, which I can't remember the name of it. Maybe it's Cunningham or something. But then it got 84.1% of the vote. They're actually a little bit more liberal up in Urbana, but so I think that we need to be getting on the stick. And and then actually, they're going to have the nursing organization is very good too. PNHP is good. Actually, as soon as this meeting's over at 8 o'clock, there's a PNHP meeting about profiteers in Medicare. So that's all I'm going to say now. But get on this, call people, learn about REACH, tell them why we don't want it. Tell them we don't want them to take away Medicare. We were so blessed to get Medicare. Realistically, when people, and when Medicare passed, older people couldn't get insurance. You can't get insurance. It costs too much. When I started my group for my employees, because what I used to do, many of them had husbands that worked and had insurance. So if they had husbands who worked and had insurance, I could pay them a bigger salary. But if they didn't, I had 2 women who didn't have husbands who worked, and I had to buy them private plans. Well, I couldn't buy them private plans after a certain time. So therefore I had to have a group. So I had, in order to be a group, I had to have enough people in the group. So I enrolled myself and my premium was $1,600 a month. I mean, it was incredible. I mean, the whole thing is like, people can't do it. I mean, it just doesn't make any sense. I mean, and we don't, you know, I mean, partly medicine's expensive here because our prices are higher. And we need to address that. I mean, because we do need to charge a lot more for things that we don't than other countries. I mean, but I mean, we're capitalists, I guess. So
I have a question. Here we're talking about Medicare, Medicare Advantage. What about the health insurance for people who are not Medicare age?
oh,
Think Medicare for all cover everybody from day one?
oh, would it? Yeah.
Okay, but now currently that would be, you would have to be on a family plan or something. Is that correct?
For Medicare for all?
Yeah, I think no. Currently, if you're, how was
So
the
currently
child?
you have to have a family plan, right?
Okay, so.
And family plan, I mean, the amount of money that the American, I think they pay like, the average family pays $18,000 a year for their health insurance. That's a lot of money. That's why people who don't make the minimum wage can't have health insurance. I mean, that's why they're in Medicaid. I mean, fortunately, in Illinois, we have Medicaid, but you know, I mean, they're still fighting in some states to get Medicaid for people. And what's happening in those states like Missouri, they're closing hospitals. I mean, because that did help some of the rural hospitals stay afloat because they had the because we have Medicaid.
Pam, I have a question. I know a gal who's a lawyer in Southern Illinois, and she specializes in working with medical judgments for I think she's advocating for doctors. And I suggested single payer healthcare, and she said, no, it would be terrible because the system would not allow the hospitals and the doctors to be paid enough, and the hospitals would close, and it would be a terrible thing.
That's not
What do you-
true. I mean, the
Okay.
theory of Medicare Advantage is you'd raise up, I mean, you'd raise the Medicaid plan. I mean, the problem with Medicaid is it pays so little. But the theory is, well, if you do Medicare for all, you would raise the rates up to Medicare. I mean, in Medicare, I mean, you can survive. I mean, I mean, it's really, you know, you're not poor. I mean, Canadian doctors are not poor. The other thing is our malpractice would go down because part of our malpractice premiums are based on the fact that we're paying for medical coverage for someone who is injured. Well, that would all be taken up by Medicare for all. I mean, I don't know what I mean, it would probably hurt her maybe, but it's really the way. And I know a lot of lawyers who believe in Medicare for all.
Okay.
So anybody have any other questions? Or, I mean, Joanne can give you my email if you want to send me a question, and I'll make sure you get that thing from the nurses.
Alright.
Oh, our live broadcast has stopped. You there? Has it stopped? We're still here, I guess.
We're still here, but we don't have your share screen.
No, I took it off.
Oh, you took it off. Okay.
Yeah, so you can see that I actually do have a face.
Right.
Well, you know, Joanne, it's my theory that when we credential doctors, we mostly never see them. So we don't know whether the radiologists actually can see, or we don't know anything about, you know, I like going to the medical staff meetings so doctors can see who's reading their slides. So, but some of them we never see. And we say like, who is that person? So, but so you can see me, and I'm, you know, I would like somebody else to help me or be involved in healthcare. And I mean, I'm going to be on those calls. And if anybody wants to get involved, I mean, yeah, that's fine. I'll work with you. You know, I mean, I just think the more the merrier, and the louder the noise we make.
I have a comment.
Mhm.
I just read this a couple days ago, and I don't even remember where I read it, but it was online. It said that one of the main reasons that big corporations like General Motors ship so many jobs out of the country was because the cost of medical care for their employees in this country was so expensive. It was adding.
Oh, it
what,
adds,
50
it adds the amount of money that the cars have to be, you have to charge for the
Right.
cars. And it's
Yeah.
true. It's true. I mean, that's why they moved to Canada. That's why they moved, other places. And that's pathetic, isn't it too? When we could do better. It's just, what happened is it would have been ideal if we had gotten, okay, the National Health Service, which is socialized medicine in Britain, started after World War II. And I believe it started, even Winston Churchill, who was a conservative, believed in it. But I believe it started because everybody in Britain knew that if they were standing on the street, they were at equal risk of being killed by a German, by German blitzkrieg. So therefore, everybody was in the same boat. And after World War II, that's what they did. They said, we're all in the same boat, so we need to have good health care. So that's why they created, and like I said, Winston Churchill believed in it. And I know that they have problems with financing and everything, but you're never going to take away the National Health Service. Just like in Canada, you're never going to take, the Republic or the Conservatives want to change, they call it Medicare in Canada, that's what it's called. But it's a political dying issue. Realistically, hopefully it's like what they're talking about, cutting Medicare and Social Security to balance the budget. You better not touch it. It's like those people said, don't touch my Medicare. It's like, no, and it's like, don't you realize the Medicare is a government run program? Because people just, don't get it. But that's why we need to keep pushing our policy. And I'm going to keep pushing Nikki Budzinski to listen to me about it. Because labor unions even believe in our healthcare, single payer, because they've lobbied so long and spent so much time and energy trying to get good health plans. And now they're getting hurt because they're cutting them. Because they would benefit by, the only thing is it has something to do with ERISA and there's some technicalities, but we could get around anything if we had to do the right thing, I think. Anybody have any more questions? But I think this was good. I hope you enjoyed it.
Yeah.
I hope you learned something, and we all keep learning. Every day I learn something. Sometimes I don't want to know it, but I learned it anyway.
Pam, if you're on a university, state university retirement system where you have your healthcare provider is sent to you by the state, and we've just switched from
Right, and they
United
did the
Healthcare.
Medicare Advantage plan.
And so we're with Aetna now, and they have a Medicare Advantage plan. You have to stay on that, can't you? You can't just say, I want to do Medicare.
No, that's not right.
Okay.
I think you should, and I'll tell you, if you look at New York City, they're protesting against the mayor badly because he wants to put all the municipal employees, fire, health, teachers, police, everybody on a Medicare Advantage plan. They're fighting it because they know about it. But see, some of these politicians, how do you know how much money the politicians get from the insurance companies? We don't know. That what sounds good, they don't even, no, just look at how stupid they are. With this thing about, getting rid of abortion, they don't even know that if you have a spontaneous abortion, you need to have a DNC so you don't get, endometritis by retaining. They don't even think about things. It's like, wow, you guys, you don't even understand why if she has a dead baby, she has to have it evacuated and she has to have a DNC because we don't want the mother to die. And endometritis is painful. So they just don't know. They think they know everything and they know nothing. And that's why, they don't even read stuff. They talked about the thing about how student debt cannot be erased by declaring bankruptcy. That was a 2-line sentence that was added into another bill and was written by somebody in the health and education department. And now he's a truck driver. So they're stuck. They can't declare bankruptcy to get rid of their student debt. Some people think that after 10 years, if they haven't made enough, they should be able to declare bankruptcy. But they can't declare bankruptcy to get rid of student debt. So, all because some idiot wrote something in it. And see, they don't read everything either. I mean, that's really sad that they don't. So, not that I still like government, but I think we need to make sure our government represents us and listens, and they try to be as smart as they can and do work for us because we elect them. Okay, well, I think that you guys, I think I've said my word, all I can say.
I thank you for spending part of your evening with us, and you certainly gave us a lot of information to think about, since I was also transferred to the Aetna plan through teacher retirement.
Well, see, I know they stuck you all in it, and that's not fair.
Yeah.
But see, I didn't even know about that till I think John Jennison or somebody told me about that.
So, okay, if there are no other questions, then we thank you very much for being with us.
Yeah, and I'm
Thank you,
looking
Pam.
forward to working with you guys too in the future. I mean, now that I met you and seen you, and now I know when you meet, I'm here.
And we hope to see you at some more of our meetings.
Okay, yeah, no, you will. I won't just be I'm not just a single flyer.
Okay.
Joanne knows that.
Right.
Pretty dogged.
Okay.
Okay, take care, guys.
You
And if
too.
you have questions, you can email me.
Okay, thank you.
Thank you.
Bye-bye. Bye.